Okay, good afternoon, everyone. In the main room, you're here because you're going to hear from one of our dynamic providers. I'm so glad to introduce, if you don't already know her, Dr. Allison Agwu. You can see all of her titles there, Professor Pediatric and Adult Infectious Disease. She's awesome. She's a dancer, too. I said it. There she goes. I've had her 2 or 3 times speak for our Women's Legends and Youngins Conference, but she's a fireball, and she's ignited behind the dandelions and those that are lifetime survivors, but she can certainly address HIV and aging across the lifespan. So my friend and my colleague, Dr. Allison Agwu. Let's give her a warm welcome.
Hello, everybody. I've been a mole in the room, watching all the things, right? So it's really my honor and pleasure to be here today to speak about something that I'm very passionate about. All right? These are my disclosures. And let's go. I have several objectives, and one is to really discuss briefly the current stage of the HIV epidemic and to really celebrate the many advances. Second is to describe the challenges, and I don't want to focus on the challenges, but we do need to talk about them, particularly the development of comorbidities over the life course among individuals with HIV. And then highlight the opportunities, including advocacy, which I hear a lot about in the room as people are talking about see something, say something. This is a disclaimer. There is no way to cover everything in the 40 minutes that I have, so I'm going to promise I won't cover everything. But there are some sessions happening now concurrently, and then Todd Brown is going to be talking in more detail about some of the comorbidities after this. So when I spoke at the Union, the online panel in the fall, one of the themes was Sankofa, and that's, you got to go back to know where you came from to know where you're going. And so this is the celebration slide where we talk about where we've come. And many of you, I don't have to tell you about this because you were there, right? The stories we heard this morning, people were there. And to celebrate where we are, where we're actually at the point where we're talking about an injectable every 2 months to treat HIV. So we are actually here with many more things coming, including cure strategies like Linda spoke about earlier. This is a celebration slide. Okay, because if we stopped at 1999, and I'm gonna, I'll be 50 this year, right? I know, it doesn't crack, just kidding, right? But when you look back, when you were telling, I didn't feel like it could step into the space to speak, because I wanted to hear your stories, but I was a med student I graduated in 1999, and the legacy for me is all the people that I saw as a med student, where you have the most time to sit and hear people's stories. People told me their stories and inspired me to be in the fight with them, and then to watch all those wards open up and people go home because ART came and people were living instead of dying, right? So it's a celebration to say this is where we are in terms of decreased morbidity and mortality. And by age group, you see that we also are seeing less people dying at younger ages, and really we're all on the march at some point, but as it should be, people should die as they get older versus younger. And so we're seeing aging and seeing people die in the epidemic older versus younger. Ronald talked about this earlier. Over 50% of people living with HIV today are over the age of 50, right? So it's the aging or the silvering of the epidemic. Many of you are in the room. And life expectancy with and without HIV, there's been a lot of data talking about this and celebrating with all the advances that we're seeing people living longer. And so when I diagnose and treat our young people, I say, your HIV is not going to be the reason why you don't do X, Y, and Z, because you have 70 years of life to live. But you see, if someone's diagnosed at HIV at age 20, their life expectancy is approaching someone who's never had HIV. Now, without antiretroviral treatment, without therapy, that life expectancy is much shorter. And these are some interesting slides just showing the general population and the different HIV acquisition groups to show, again, increasing life expectancy, decreased mortality. Now, I want to stop here for a second just to point out, I'm not going to use a pointer because then I'll have to let go of my mic, but what you see at the top is years of without HIV infection versus HIV with HIV, and you see essentially, again, life expectancy increasing. So median age of passing away, remaining age, diagnosed at age 21, how much life you have without HIV infection versus that with HIV. And then what you see down here, what we're going to talk about is comorbidities, right? And so not just living, but how are people living? And you see people without HIV are more likely to have comorbidity-free years. That means years without hypertension, without diabetes, without obesity, without lots of things, while with HIV, the number of comorbidity-free years is fewer, okay? So how do we address that? And that's what we're going to talk a little bit about today. I would be remiss, and I don't think anybody's ever given me a talk where I don't lift up the individuals who are born with HIV, right? I think if they were in the room, and I don't know if I see any in the room, they oftentimes felt forgotten, and so I really do appreciate hearing them constantly mentioned in the dialogue, because they're here. This slide is older, and I have not seen newer data, but there are about 12,000 of them born with HIV that are living. And now, this actually is more. You see the median age is around 20 or so, but significant amounts of them are actually approaching 40, right? And many of them in our own clinics. That is a clap, okay? But I would also want to make sure that we highlight that we continue to have new diagnoses despite PrEP, despite all that we know. And the silvering of the epidemic could also include the 4,000 people over the age of 55 that are still acquiring, but also looking to see that we still have a lot of people acquiring HIV, particularly in the middle adult years and a lot of adolescents. Okay, so I talked about the bookends, the young and the old, right? And I'm part of the old, I'm getting there, right? But I think what we don't know is what's gonna be what happens with lifetime survivors in terms of what their comorbidities are, and then what about those seniors who are acquiring HIV when they already have comorbidities already present? What happens to them? And also, we're in uncharted territory, right? Miguel, the Lisbon patient, died at age 100, right? A couple of years ago, 2019. So what are we gonna see as we age, as we start to push the envelopes? What else? So, first and foremost, I saw you all cutting up out there. Many of our lifelong survivors and long-term survivors are thriving. Some of you see yourself on this slide. They're thriving, they're living, they're doing all kinds of things. You are living and doing amazing things. And so are many of our lifetime survivors, okay? Many of our lifetime survivors are doing everything. And I also want to hold up Hidea Broadbent, who we know passed away earlier this week, right? Doing amazing things. The continuum of care we oftentimes talk about, and we oftentimes lament about how we are not suppressed, how we are not. And I oftentimes say with so many of the social determinants and things, we need to lift up how it is that 50, 60% people are suppressed, right, versus focusing on the ones that are not. And thinking about how we meet people where they are so we can optimize the things that will help them get to suppression, engagement, et cetera. So just want to say that there, right? Let's flip the dialogue a little bit and not focus on the things that we're not doing well and how do we focus on the things that we are. With that being said, we know that continuum of care is challenging across the life course, all right? This breaks down overall, even with all the medications we have and all the strategies, about 60% of individuals are virally suppressed, which is the goal of the continuum. And those in this age range, which includes many of our lifetime survivors, have lower rates of suppression. So how do we get there and what are we seeing? So what are we missing? What are we missing? I think it's important to say we're missing life. Life is dynamic, all right? It is not always you have so many things to do and it's a bad thing. I'm trying to live, actually, and that's why it's challenging to take my medications. I'm on my grind, and that's why it's challenging, right? So when we're advocating, it's thinking about what is it that brings people to here where their continuum is not perfect. And so adherence is hard and multifactorial, right? And it can be different on any given day. Side effects, comorbidities, there's long-term toxicity, including short-term toxicity. There's the one size does not fit all, and it may not fit the same person on any given day. It may be good today, but not good tomorrow. And so how do we meet people literally where they are with that? Forever is a really, really long time. I take care of a lot of young people, including from infants. I always say I diagnose, and then my goal is to prevent all the comorbidities going forward. But when I tell a 20-year-old that you're going to take medications for life, that's a long time. So how do I meet you where you are that I can optimize that for you, where it's palatable for you, where you just say, I can't do that. Fatigue. Doesn't matter how easy that one pill once a day, you could just be tired of taking that one pill once a day. Disclosure, even for ourselves, every time I take that medication, it reminds me of that, or I'm going to disclose to somebody else because I'm taking that medication, right? And then stigma. We have come a long way and nowhere at all. Okay. And then mental health and isolation. So all these things are happening in terms of what we're missing in the life course. So this is a paper that I myself and my postdoc put together, where we really started to really focus on this idea of what's happening over the life course. And there are things that we miss, so I want to make sure that you call them out if you see them. But thinking about from lifetime and long-term survivors, what's happening at each decade of life, right? And how that can factor in, from life events to self-management, who's actually helping you with your medication. Are you taking advantage of that? Are you taking it yourself? Disclosure. Disclosure takes different forms, from you getting to know your diagnosis for our lifetime survivors to disclosing again and again and again. It's not a one-time affair, and I don't have to tell this group. It's disclosing to yourself or finding that out. It's then your parents who may be disclosing to you that they also are positive. It's disclosing to partners. It's disclosing to children. It's disclosing to grandchildren, right? And all of that can have impacts on how you then engage with your medications in life. And then stigma, both internal and external, is real, even though it's better than it used to be. And then our treatments have evolved, and depending on where you are and where you join the treatment journey, we have simple regimens to super complex regimens, because while it's great that we have injectables and Cabenuva, a significant number of individuals, including our lifelong survivors, can't take advantage of that because we're so adherent to our one medication, our ACE-serial monotherapy, and then dual monotherapy or dual therapy, that they are not able to take advantage of our injectables. Adherence may wane over time, right? Even as committed as you are to taking the medications, it just can be challenging. And that can evolve, again, depending on where you are. The comorbidities change over time. Where you get your care, how you get your care, who gives you that care, changes over time. And then risk factors. We are at that point where in the younger age ranges, we're accumulating modifiable risk factors. So where many of our patients live, they're food deserts, but they're also places that we are pushing alcohol, tobacco products, right? At the same time, many of our grocery stores, they really are targeting our young people, and so they're accumulating those modifiable risk factors. And then as we age, increased weight gain, engagement in modifiable risk factors, including for our seniors, who we oftentimes don't think about or want to talk about. So let's talk a little bit about that. Sex. Okay, one of the sessions is happening then. I wanted to bring this up because for one major reason here, this is how prevalent sexual activity is over a lifetime, right? And you notice something really crazy. It stops at age 40. Offensive. All right? So when we talk about comorbidities, we oftentimes talk about that as a young person's thing. Our seniors are having sex. There's actually a session right now that Stephanie's in there leading, talking about sex. And so life course has to include all parts of their lives, our lives. All right? Seniors are having sexual activity. 40% of seniors are sexually active. There's a lot happening. And so thinking about people's life course, we can't just say it's about their medicines or it's about their comorbidities. It's about all of their lives. Because if we're not talking about all the aspects, we can't then really think about how we're going to impact fabulosity. Okay? So since we're going to talk about comorbidities, I wanted to put this up because this is the most common cause of death. This is not HIV specific. This is across all Americans, right? People with HIV are dying from the same thing that all Americans are dying from. That's exciting to say, right? Because before it was HIV that was the thing that people were passing away from. Now it's the unintentional injuries, it's heart disease, and more heart disease, and more heart disease, right? This is by age range. This is the breakdown in terms of trends and annual rates of death among individuals with HIV. And what you see is HIV disease itself is less the cause of death. It's the other things. And so we have to start thinking about how do we optimize people's living with and beyond their HIV. This is just showing this in a different way, broken down by race, ethnicity, and showing essentially among Black, African Americans, we have higher rates of HIV causing disease because there are low rates of disparities in terms of treatment, access to care, et cetera. And so thinking about that is going to be really important. In terms of comorbidities, I told you that Todd Brown was going to talk more about that, but I wanted to really just sort of highlight, just again, patients with commercial insurance versus Medicaid, seeing, again, rates of cardiovascular disease, kidney impaired, osteoporosis. People are having comorbidities. Why? Root cause is inflammation, right? And not just inflammation, I think we have to think about all the things that intersect to cause our comorbidities, but inflammation is a big part of that. Inflammation in some ways is good, right? And Todd is going to talk in great detail about that. But it's our body's attempt to self-protect ourselves, to remove harm and stimuli that's causing it damage. But as your body goes to clean that up, that inflammation itself can cause additional damage, right? And so chronic inflammation, or that prolonged inflammation, leads to active tissue injury, rehealing, and cycle, which causes over time damage to our body and our organs. And that heightened inflammation can cause many disease states. And so putting it all together, that chronic inflammation that we see in HIV, cardiovascular disease, Alzheimer's, metabolic disorders, cancer, musculoskeletal disorders, all things related to your HIV, even when people are suppressed. There's some really great data on pediatric patients who are long-standing living with HIV, who have suppression for long periods of time. And even in those individuals who are adolescents, even with chronic non-viremia, so no viremia, no virus in their blood, undetectable, they still have inflammation, okay? HIV itself is thought to be an independent risk factor for inflammation. So even when it's relatively controlled, itself adding on, it's the extra finger on the scale leading towards additional inflammation. So putting it all together, right? So it's HIV, there's age-associated diseases, there's all of the pieces all coming together. I'm trying not to take Todd's thunder because I saw his slides and he's going to talk a lot about it. So Todd's going to be okay? So just showing that there is a framework of how it all gets together, okay, and results in inflammation and long-term comorbidities. So the intersection of HIV, aging with HIV, and then add a sprinkle of the medication toxicity can lead to the increased probability of comorbidities. Okay. This is always the picture. I think probably until about 4 or 5 years ago, it was always a silvering. And this is when I said many of our young people felt really left out of that. You're smiling, some people see. Yes, spill the tea. Felt left out. And so the question was, what happens to the lifetime survivors where, you know, acquiring HIV at 20 or 25 and having inflammation is one thing. Acquiring HIV in utero where your entire existence has been in the presence of HIV, how is that different for you? And so again, I cannot say enough how excited I am to be having the conversation about the collective. Okay. This is a study I was telling you about in terms of long-term suppression and having people suppressed for long periods of time and still seeing, despite chronic suppression, still having higher rates of immune activation, meaning inflammation, immune activation for individuals who were born with HIV, again, despite suppression for greater than 5 years. So never getting to the immune activation or the activation levels of people who don't have HIV at all. And so how will lifetime survivors be impacted? Really, it's how will everybody be impacted by HIV? This is, again, I always hold up because you're all new to this. This is the comorbidities among those who are HIV positive, plus or minus ART, and looking at the different things that we know are happening in terms of comorbidities. Again, more focus on the lifetime survivors here because I want to really make sure we understand that they are having these comorbidities, absolutely. Okay. And just showing the range of comorbidities that they are having. This is a study, again, also showing that. Pregnancy is not a comorbidity, but you are more likely to have a pregnancy in younger ages, and then you intersect Black race, and we know comorbidities or among pregnant women is higher, and then you have Black females and HIV, so you have higher rates of comorbidities. So just thinking about how it all links together. This is data from Jason Hall, who looked in the NE Accord, which is a huge cohort among United States and Canada, and looked at perennially acquired individuals and showed higher rates, 1 in 5, kidney disease, diabetes, showing higher rates essentially compared to the general population. I'd be remiss if I didn't spend some time talking about mental health, HIV, and aging and how they all intersect together. I think we do know, I've talked about inflammation, how that impacts the brain. HIV itself, even in the setting without replication or more virus turning over, can impact the brain. But then you add the current antiretroviral therapies and their toxicities, polypharmacy. There's some nice data showing the number of medications that people as they age are taking and how does that impact the brain, particularly as our ability to process those medications are lower and the impact they have on our CNS is higher. And then things that I think are unrecognized, adverse childhood experiences and trauma and violence, and how does that impact our brains and our mental health and our processes. And then early impact of HIV infection in the CNS, so either with lifetime exposure to HIV in the CNS or the period of time you were positive before you got virally suppressed, and how does that affect the brain. And then there's just neurodegeneration that happens with aging. Without even adding HIV into the mix, what's happening with us as we age? Again, mental health, HIV and age and how it intersects. There's aging itself, and I think we are learning. COVID taught us really sad lessons about what isolation does to people's brains, right? And we force people to be in their houses, a way to protect them, and saw higher rates of depression, saw higher rates of actually progression of diseases because isolation depression can actually worsen that. And so you put declining health, fatigue that happens in aging. We are not a good society for aging. We're not. We do not take care of our seniors. Okay, and so I think that's highlighted even more with HIV. And so HIV itself and then the two together, and how does that impact collectively? I want to spend a little bit of time talking about dementia and HIV. I think this is a field that I think is emerging, or we're hearing more. First of all, dementia rates in the US are skyrocketing. Currently, there's about 6 million people greater than 65 years of age with HIV, 65 years of age who have dementia. About 200,000 individuals who are under the age of 65, so early onset dementia, right? Women are 2 times as likely to be impacted, and we've seen the rates markedly increase among Black and brown. Again, an area, a population that's more impacted by HIV as well. In a study of Medicare patients, looking at all patients over the age of 65, they compared dementia rates to what was happening in individuals with and without HIV between 2007 and 2019, and saw increases in dementia rates and dementia and also dementia-related illnesses. This is for HIV negative, from 21 to 24%, 27 to 30% among those without. But look at the rates for people living with HIV, 26 to 33% for males, and 31 to 44% for females in that same time frame. So what's happening? The dementia burden was highest for those the oldest ages, older than 80, and for females. And so with that, it's prevention, screening, care, research, and not excluding people with HIV as we think about research for dementia and what's happening cognitively. I highlight the dementia risk factors because there are things, one of the things we want to think about is what can we change, what can we modify, right? What can we modify? And looking, there's more and more data in terms of what are the things that are contributing to dementia. There are going to be new agents and things coming forward to address dementia, or at least hopefully as we figure out what proteins and things are involved. But there are things that we can do now, positive or negative, to decrease our risk of acquiring dementia. So, risk factors you can change. So, how will we know what's happening? I asked this in every room. How will we know what's happening? Interestingly, everybody, dolutegravir a few years ago, it's causing weight gain. About 5 years before that, in our women's clinic, the women were saying, I think I'm gaining weight. How do you know? You ask the people. You ask the people, okay? The voices of all individuals with HIV. Listen to what people say. Ask them and actually pause and listen, and they'll tell you. And then the research should follow that. Case reports and series, see something, say something. I've spent a lot of time collecting the stories and then using my voice to highlight what I have heard from the people. Observational data are really important. Longitudinal cohorts are really important. Taking a group of people and saying, well, let's follow you so we can see what's happening. And there are many cohorts here. And then modeling studies, including those like in Boston, the CPAC studies. And none of the cohorts are all inclusive, but we have to make them as inclusive as possible to make sure that we include everybody. I always highlight NA Accord, because NA Accord, when we ask, well, how many perinatally acquired individuals did you have? They said, oh, we don't have that many. And actually, it turned out they had a significant number of people under the age of 30 that had unknown as their risk factor. So when they went and looked, actually, there were about 400 that they had right in hand that were perinatally acquired, that we could actually figure out what was going on. And this is one of them. This is one of their hearts, showing a heart attack, and again, talking about the NA Accord data. So I really want this to be about what can you do, because sometimes it feels very heavy, and sometimes I think triggering when we say this is what's coming, this is what's coming, because I think there are things that we can do. There is prevention. I'm Black. We don't talk about our family history. We don't talk about it. That person dropped dead. I'm Black and Caribbean, so we really don't talk about it, right? We don't talk about mental health. We don't talk about anything. So what is a family history? Because that actually adds to your risk. So those are the risk factors that you can't change, but you gotta know about them to know what to do. Lifestyle modification, so key. It is never too late to modify. It's just never, okay? So stopping smoking, exercises, walking, decrease stress. Thank you for that session earlier today. Just breathing, intentionally breathing, can help to decrease stress. So hope you took that with you. In the car, when someone cuts you off and you wanna cuss them out, take a deep breath, right? Increase your lifespan. Okay, sleep. Blow a kiss to them without holding up the middle finger. Blow a kiss. Okay, vaccines, all right, all the things to decrease risk. Screenings, physical, mental health screenings. Okay, treatment of HIV and the comorbidities. Adherence is important, because I think I told you there is still going to be inflammation, but decreasing that inflammation as much as you can with ART and then the other things. Hypertension, high cholesterol, glucose management, all these things really important. Mental health counseling and treatment, and pushing our insurance companies to cover mental health and treatment for people before they are at the end of things. Cancer screenings and preventive measures. And there have been new data recently in terms of anal cancers and prevention with screening and doing something differently about them. I would be remiss if I didn't talk about Reprieve. Who's heard about Reprieve? Okay, so this is really important. There's actually a study, it was a 5,000 person plus study looking at lipid-lowering agents for people 40 and over living with HIV, and did not actually qualify for lipid-lowering agents, so cholesterol agents, and did a study, randomized controlled trial, double-blinded, to put them on cholesterol-lowering agents versus not. And actually, it made a difference, decreased heart attacks, strokes, cardiovascular events. And so if you have not heard that from your physician, and you are in that 40 or above, it may benefit you to be on a lipid-lowering agent. So these are the kinds of things. How do we prevent? So we don't just talk about what's happening, it's how do we prevent? Advocacy. Decrease the stigma, talk about it, push for research, push for this population to be included. So I think initially in terms of how we improve outcomes, I think it's multimodal strategies. I'm so excited about the injectables, but they're not for everybody. What about implantables? What about dissolvables? What about what else? What, right? What about long oral pills, right? That it's about everything, expanding our armamentarium and thinking about people who have drug resistance, because they can't just be, this is not for you. Well, what else is there and how do we get that for you? Different delivery modes and strategies are key. Addressing comorbidities, I've talked about this, but screening, prevention, it's much better to prevent, right, than to treat. So can we prevent? Can we talk honestly about how we need to be prescribing good diets? Not just telling people to have a good diet, but what does a good diet mean, right? And can I give you a prescription for a good diet, right? Can I give you that, and you can actually go to the store, and can we pay for people to get healthy foods? Just things like that. How do we prevent in a way that's meaningful? I think we need to rethink the risk scores and calculators. Young people, our lifetime survivors, are not included. Those who are under the age of 39, they're not including many of the risk scores that we have. So how do we think about them when we talk about things that can prevent? How do we consider them more effectively? I think we need to think about improving engagement strategies instead of just telling people, come to where we are. How do we meet people where they are? Because if we can meet people where they are, then we can talk about prevention, comorbidities, and address that in a way that meets them literally where they are so we can make a difference. Address isolation intentionally and address mental health meaningfully. We need to optimize our care models. I take care of a lot of young people and come to see me once every 3 months, or even my older people, because I have some older patients, a lot of them, come see me every whatever time. They can't get there. Transportation's an issue. So how do we modify our health systems to meet people literally where they are? How do we use technology? How do we use personalized medicine? And then our research must include all our long-term survivors, intentionally. We must revisit the eligibility requirements for our research, and then we must intentionally recruit and engage all of the people. Okay. This is the NIH's panel. Let me go back for a second. The NIH's framework for research moving forward, and comorbidities and addressing comorbidities is front and center. But oftentimes, again, we have to think about this along the entire life course. Right? So there's really emphasis on thinking about all aspects, and it's important for you to weigh in on whether you think they've got it all right, including research towards a cure. And when I talk about cure, because I have some roles in the cure collaboratories, I always have to hold up people who have been living with HIV for a long time, who say, well, that's great that you're talking about cure, but what does cure mean for me? Who am I without HIV? Right? We oftentimes think about, I think everybody, the researchers, just getting rid of HIV, but thinking about what it intentionally means for people and how HIV has played a role in their lives is something we have to think about qualitatively as well. Sometimes as a provider, the prescription that I can give is a hug. I did that this week. I can write your ART, but I have to see you and touch you to make it better for you. And then again, advocacy, resource funding. Funding. Somebody said vote this morning. We have to vote because they're coming for the HIV funding. They're coming for it, right? It's not as important anymore. So they're coming for it. So please vote, please advocate. So in conclusion, because I have 5 minutes left, long-term and lifetime survivors of HIV are aging and many are thriving, again. There are unique challenges and there are potential comorbidities that impact outcomes across the entire lifespan, and we have to, again, see something, say something, and we have to be aware of the potential impact of what this may mean for young people and the whole spectrum of people living with HIV, young people, all of us. And then we need to include the diverse aging groups when we think about it. Again, holding you up in positivity for including the entire spectrum of people aging with HIV. That has to be intentional, and we cannot leave people out as we think about that and move forward. With that, I will stop, say thank you for your time, thank all the survivors that I work with, and thank you all for your attention.
Well, I don't really have a question. I also have a statement. Yeah, I think I'm pretty loud. Am I loud?
No, you're recording.
Oh, I'm sorry. Well, I don't really have a question. I also have a statement. I think that your presentation was terrific, and I love how you definitely brought us through so many different levels when it goes into long-term survival. Even talking about like stigma, I don't think that stigma may have gotten better or may have gotten worse. I think that we have seen stigma evolve. So whereas it used to be that, we did not have social media and things like that, but as far as it may not necessarily be in your face physically, but I do definitely believe the stigma has evolved into like social media and things like that. So when you think about, to me, like when I think about HIV and long-term survival, I always think about that kind of like iceberg Titanic kind of situation that you always got to go underneath the iceberg. And I definitely appreciate your presentation because it definitely did that we can not only say, okay, take the pill and you'll be okay, but we also got to think about all of those other underlying issues. The one, make sure that we have the correct medication for the person. I think that sometimes we do have so many providers that may just say, okay, this is the top medication so this is for you. But they may not look at that medication, see that, for for African American men, it may be bad for our kidneys. They may not think about for a person that have mental trauma, it may cause you dreams and things like that. So I think having those conversations with the provider and the patient is extremely important. And I definitely enjoyed your presentation, and thank you so much.
Added information about stigma. Stigma is not linear. Stigma is multi-layered. Okay? For instance, I am a black woman. I am an older woman. I had 10 comorbid or co-occurring chronic conditions prior to acquiring HIV. So I already had, I'll be 72 in June. I was born with those illnesses, and so that I have physical, visible and invisible disabilities. So I have all these things. Then there's classism, colorism, you can keep adding. So when you talk about stigma, it's not a linear thing, and it's all underneath the iceberg. That's the top that you see. All of the rest of it is below, but you're dealing with it.
Got a question over here.
Thank you so much, Dr. Agwu. Appreciated the presentation. Is always excellent. I just wanted to ask you this question when we were talking about treatment. How are things going as far as younger people using the injectable for treatment? Just was wondering.
So this is a great question. So as you know, Dorcas, the injectable Cabenuva, which is cabotegravir is approved all the way down to 12 years of age. It was approved about a year after it was approved for 18 and older, and we actually did the studies at Hopkins. I will say the first youth in the world who got injectable was a young man from our pediatric clinic. Okay? Research is a right, okay? Research is a right. So in terms of actually getting out, there have been some access issues in terms of the injectables being rolled out. So our pediatric patients under the age of 18, had to go with the adult side. So that was a bit of a challenge. We've now rolled it out in our PEDS program, and we are seeing increasing numbers of young people choosing to move to the injectable. So I think the rollout has been a little bit slower on the PEDS side, but it's actually happening definitely with increasing numbers wanting to be on it. And you have to be honest with people that there's discomfort, et cetera, but the quality of life that they have described with moving to injectable, I think is unmatched. They just getting their shot every 2 months, absolutely. So there was just recent data this week from Latitude, which is the study that looked at injectables for people who are not suppressed, because currently they're only approved for people whose viral load is already suppressed. So this is people over the age of 18 now who were viremic or had viremia, now has proven that actually injectables works better, which kind of seems like a no-brainer. So we're actually doing some of those studies in terms of choice and getting injectables to younger people. It's a great question. I've said for years, it's about choice. It is about choice. How do we optimize choice?
Oh. I got no question.
Hi, thank you for a really great presentation, and I took lots of photos of slides, so I'm going to use them. I do want to just connect the dot on one thing that you said at the very end, which is really important, because the slides show the leading causes of death, and then it shows the disparity for different populations. But one slide that you didn't show, and it's on the CDC page, is that AIDS is still a leading cause of death or AIDS-related conditions, including those that cause mental health, drug use. We think about Hadia Broadbent's death this week at 39. It's still a leading cause of death for black men and women between 25 and 44. So when you say unimportant, that's important because some people don't believe those lives are important. The other thing is when we say they're coming for AIDS funding, it's not just because it's unimportant in the way we think about, but because Steve Bannon and the Heritage Foundation consider AIDS funding as part of the deep state. And when they say the deep state, what they mean are programs for people and funding that hold up institutions in communities that oppose conservatives. So they mean if you get rid of AIDS funding, you destabilize black communities, you destabilize LGBT communities, you get rid of the deep state that opposes them. It's important that we understand these connections because sometimes when we hear the deep state, we think of those bureaucrats that sometimes we don't like too, but they mean us. They want to destabilize LGBT communities, and they know that 70% of the institutional money comes from government funding of HIV. So that's the dots they've connected, and they're acting on it.
Thank you for that. I mean, I think yeah, no, absolutely, completely agree with you. So I didn't mean to rush through it. Absolutely, absolutely. You see here on the slide, this is a black African-American community, and HIV on this slide still remains high. So it's not disaggregated by age, but absolutely, it remains an issue. And I think you're right to put it all together. The intersectionality cannot be ignored, right? We are here for the same reasons, and they're coming for the funding for the same reasons. And when you layer the tables and the figures that have places where, honestly, slavery was most, where hypertension is most, where racism is most, it's all the same places and layers. Exactly. They're all layered. And so this attempt to disconnect or disaggregate them is actually, it's a Jedi mind trick. It's all the same thing. So thank you for highlighting that. Thank you so much, everybody.
Thank you, Dr. Agwu.